Good evening and welcome to the discussion on physiology of the renal system. This is number 6 in a series of 8 different lectures on the physiology aspects of each of our body systems, how they fit together, and the importance of learning that interconnectedness as a nursing student, and also to start learning a bit about how each body system impacts what we do for our patients, learning about how to take our NCLEX exams, and also a little bit about nursing diagnoses and medication. So without further ado, let's get started on our renal system. Okay, so here we go. As we have been working through our program over the course of the last several weeks, we're building one system upon another. The last system that we did was endocrine yesterday, and that's recorded and can be found in the weekly tutoring teams icon section. The recordings are in the chat section, and I've also included some notes and some suggestions as well. So again, my name is Professor Lisa Leshko-Evers. I've been with Concord for about 2.5 years, and I look forward to sharing some insight on the renal system. So as we have done previously, we are using a systematic approach on how we are going to discuss the systems that we lecture upon. We will talk about the purpose of the system, some basic physiology about how it normally works, along with some common labs. I do encourage you to use your RN notes flip chart so that you can get familiar with that. It's the book, the little booklet that is sort of yellowish on the front and has 8 sections, divider tabs at the bottom, and labs are in the, let's see, labs and EKGs begin on page 194. So just start using all of your resources. We'll talk a little bit about pathophysiology, some main nursing implications to consider, and we're going to use a format of looking at the 4 client needs sections, because that's how our NCLEX exam for licensure is set up. I also encourage you to think about 3 common meds and classifications to learn with each of our systems, and we'll touch upon some HESI hints also. So as we've done before, this is, if you've joined me in the past, this is going to be a review, but we need to be familiar with the main categories of the 4 client needs that are covered is how we focus our knowledge in nursing school. And you will notice as you're going through each section of your adult health book that you will find these categories in the learning sections, or excuse me, learning outcomes portion of each chapter. So for this particular chapter, we are, this is chapter 65, and it is on page 1321. And so the learning objectives are broken down into these 4 categories: safe and effective care environment, health promotion and maintenance, psychosocial integrity, and physiologic integrity. And so this is how we are going to approach each of our body systems as we go along. As I mentioned when we kick this off, the most important thing I'd like for you to take home from each of our lectures is that each of the systems and each of the courses that you take throughout nursing school are not standalone. They are building one upon another. Everything within the body is interconnected, and as a way of sort of depicting this, I've used this particular diagram through each of the sessions, and it really does drive home how everything works together. And you'll see here especially how, oops, I didn't mean to fast forward. I didn't mean to do that. Okay, you'll see here especially how things fit together within the adrenal cortex and the kidneys in reference to aldosterone. So how and why is aldosterone even secreted? So what happens? the body senses that there has been a decrease in blood pressure, right? So let's just start here. This is always fun. So here we have a decrease in blood pressure and a decrease in extracellular fluid. So we're like, what's going on? So the kidneys secrete some renin. And it's like, all right, there's decreased renal perfusion to the kidneys, which by definition means that there's been an acute kidney injury. So we're like, oh my God. So if we have decreased blood flow, that is a pre-renal issue. So that could happen for a variety of different causes, right? Whatever, maybe they were in a serious accident and they lost blood volume and that decreases their blood pressure. So as a result of that, there's decreased blood flow to the kidney and the kidney goes, whoop, we're going to have to do something about that. So it secretes renin. The renin goes along and hooks up with angiotensin 1, the angiotensin converting enzyme. It goes to angiotensin 2, and the angiotensin 2 triggers the adrenal cortex, which is sitting on top of the kidney, to secrete aldosterone. That aldosterone makes the body go ahead and reabsorb water and sodium. When it does that, it goes ahead and increases the extracellular fluid. And by extracellular fluid, it means like the blood plasma, everything that's around each of the blood cells themselves. So if you've lost a lot of blood volume, you've lost plasma and stuff with it as well. So you're going to retain the sodium and water. That's going to give you volume expansion. And as a result of that, you're going to increase the blood pressure. This is fabulous, and this shows clearly how the blood pressure can be maintained, how we maintain homeostasis, and how each of the body systems does work beautifully together. So what actually is homeostasis? By definition, it means homeo means same or similarity. Stoppage is what stasis means. So what happens is when the body systems get back to the sameness location, whether it's blood pressure or concentration of electrolytes or any of that, it reaches that homeostatic place, and so any changes basically pause for a bit. So by definition, back in the 80s at least, in Mosby's, which I still have, homeostasis is defined as a relative constancy in the internal environment of the body, naturally maintained by adaptive responses that promote healthy survival. The thing I always point out here is that the body is created by the maker, whatever your belief system is. You don't just spontaneously generate, to naturally adapt and to be healthy. So what we need to do is just support that and try not to mess it up. So how is this all accomplished? The homeostasis is accomplished by the body systems working together in a healthy environment, allowing for the ups and downs and seeking the balance, seeking the mean, which is fabulous. So with the renal system, our goal here is to maintain body fluid volume and composition and creates urine for waste elimination. Pretty basic, right? So as we said, that's sort of a nice overview of the purpose of the system. And I'll read a little bit more out of our green NCLEX book because I really do like this NCLEX review book, chapters 58 and 59 for the renal system. 58 goes over renal and urinary system, and then 59 talks about some renal specific drugs. You'll most likely, I believe, find the diuretics in with the antihypertensives. I think there may be a few diuretics here, but and then of course you have your pharmacology resources as well, which are all helpful. So our purpose is to maintain fluid and electrolyte balance and to do elimination. I'm going to read through this really quickly just as a quick overview, and then I'm going to hopefully kick off a YouTube video which I think is so helpful because the gentleman does a fabulous job and there's actually movement of flow through the urine and the nephrons and such, and I think it's a lot easier to see that versus just hearing words. So obviously the renal system is made up of the kidneys, the functional unit, which is the nephrons, the ureters that exit the kidneys, the bladder that holds the urine, and then the urethra that exits the body. From a physiologic perspective, in addition to what it does, it also, that we talked about above, it secretes renin, which we talked about as far as blood pressure maintenance to regulate BP, and also it secretes erythropoietin to stimulate the bone marrow to make red blood cells. And those are two really important things. And I say that they're two really important things because in the green NCLEX book, it has a fabulous pyramid diagram alongside of it, which basically means it's an important point and that you should be familiar with it as you study for nursing boards and passing nursing school. The most common labs that we deal with the urinary system are creatinine, BUN, and urinalysis. We're also going to touch upon the electrolytes in this session. Common pathophysiology. Anytime that there's a rapid decrease in kidney function, it leads to a collection of metabolic waste in the body. So anytime there's impairment like acute kidney injury due to hypotension, things back up within the kidney, waste accumulates, and then we start having problems, and it's much harder to seek homeostasis. We'll also talk about our 4 client needs as they pertain. We'll choose one of the 4 client needs as it pertains to the renal system, and we'll also talk about some common meds and classifications to learn. So let's see if we can get our system here to kick off and to continue. Okay. I hope this works, and if not, we can talk through it, but I appreciate your patience as I try to get this up, and hopefully that's going to work. Oops. Hide presenter. I want to go back to, oops. Oh boy. I appreciate you giving me a chance to get this going. And I know that it's sometimes difficult as we're going through this to change screens. Listening, all right, don't know what that means. Okay, I think I'm trying all of my fabulous stuff here. Oops. Well, this is going interestingly well. Well, what we'll do is I will continue going along through here, and oh boy. Let me get back to presenter's view. And what I'll do is at the end of the session, I will play the recording of the PowerPoint, excuse me, of the video that I was referencing. Thank you so much for your patience. I thought that would work easily, but it's probably me as computer error person. So let's talk about the 4 client needs categories and which one we're going to choose. So the one I chose specifically to just touch upon for this session is number 4, which is the physiological integrity. And in our textbook, number 4 has as a learning outcome to apply knowledge of anatomy and physiology to perform an evidence-based assessment for the patient with a urinary elimination health problem. And you can find that on page 1321. Whenever you look at your learning outcomes, you then look at the end of the text, and as you've read through it, you look at the highlights, you focus your energy to try to be able to answer the questions or the outcomes that are discussed, and then you can flip to the end and look at the key points. And in the key points, typically you will find a summary, a quick reference of how you might address that particular learning outcome. So in applying knowledge of A&P in reference to the urinary elimination health problem, what we need to be able to do is interpret lab data to distinguish between dehydration and kidney impairment. So how do you do that? Is there a quick lab value that you can look at to distinguish the two. And the quickest and easiest way to distinguish between dehydration and kidney impairment is to look at the BUN and creatinine. With dehydration, you will find an increased BUN, which typically comes and goes. But with kidney impairment or damage, you will see an increase in the creatinine level. And that typically happens when I believe like 50% of the nephrons are damaged. So we'll go over that again, but that's sort of how I'd like for you to approach each of the learning objectives during each of the assignments of the chapters as you're going through nursing school. You'll find that to be most helpful. So from pathophysiology, an acute kidney injury, AKI, replaced older terminology like renal failure was what they used to say. So this is an acute kidney injury, which happens as a result of just a rapid reduction in kidney function that you'll see in a course of hours or days. Often happens as a result of blood loss or fluid loss for some reason, either from trauma. You could actually also have a burn where you have third spacing and you lose fluids into the third space tissues. Hypotension results in a heart attack or MI. Heart failure can also cause the same thing. So when you're going through your acute kidney injury scenario, you'll notice that there's 3 types. It could be pre-renal, which is perfusion has been reduced, the blood flow to the kidneys has been reduced, and a heart attack is a common cause. It could be intrarenal, meaning that for some reason the nephron has been damaged. Oftentimes that's from infection, like a severe pyelonephritis or something like that, lupus, which is an autoimmune disease, and drugs. Anything that's nephrotoxic could cause intrarenal damage and result in acute kidney injury. And then post-renal, most common example would be kidney stones. So again, here is that slide that we loved before. As the blood flow or the blood pressure decreases and we have a drop in our blood pressure, that causes the kidney to secrete renin. Renin will get that renin-angiotensin cascade going so that basically the angiotensin 1 turns into angiotensin 2, complements of the angiotensin converting enzyme. The adrenal cortex on top of the kidney is stimulated. Aldosterone is secreted, and then aldosterone tells the kidneys to increase sodium and water retention, reabsorption. So it goes back into the vasculature, does not get excreted as urine, and then the fluid levels increase and blood pressure stabilizes and increases. So all the systems influence our bodies, most definitely. Here is a fabulous slide that shows the nephron and also the renal physiology and diuretics. I did it on one slide so that you could see them side by side. And so what we'll do is would love to be playing this video as we're going through this, but I'll talk you through this just a little bit. And then what we'll do is at the end of our session together, we will go ahead and I will play the video as we're still recording. All right, so the nephron is the functional unit of the renal system, correct? And basically you've got the afferent blood flow coming into the renal system and then goes ahead and gets filtered through the glomerulus. And then actually what I'll do is read, let's see, yeah. So I was saying the best way to do this, as my plan had been, was to go ahead and see everything flowing through the nephron itself. So the big issue with this is to go ahead. All right, so here are the afferent arterioles, and by afferent, we mean that it's being added to the system. So it's being added to the glomerulus, and the glomerulus is where the nephrons are located, and the was I going to say? The Bowman's capsule surrounds that. So the urine gets filtered, excuse me, the blood gets filtered through all of the loops within the renal system, within the nephrons themselves. And then what happens is the the water and the solutes, the sodium, the chloride, all of the good stuff is reabsorbed if needed. And then what is collected into the collection tubules is actually urine, and that would be the waste. So as we're looking at this, the proximal collecting tubule, this is proximal collecting tubule, PCT. The colors here is the section or the segment name is in purple or violet, so that is proximal collecting tubule, and that's over here, proximal collecting tubule, and the type of diuretic that acts there sometimes is an osmotic diuretic. A couple of these will function in a couple places, and there's a summary at the end. There's also another medication that works here at the proximal collecting tubule, and that is Diamox. It is carbonic anhydrase inhibitor, I believe, and that is acts on the proximal collecting tubule, if I recall correctly. The green is what's secreted. All right, so different things are secreted here. So the creatinine, antibiotics, diuretic, and uric acid are pulled out of the body and they're secreted. And what you could see is the reabsorption, things that get reabsorbed into the body versus being excreted in the urine. So the yellowish stuff here is what is actually going to be excreted as urine, where the arrows are going, that means that those particular substances are being reabsorbed into the body system, into the bloodstream. All right. And so it's all, I mean, to me, it's just super fascinating. And the more you learn, or the more you see it, various different ways, the more clear it will become. And I think that one of the last slides that I have basically has the renal physiology and diuretics without the flow of the electrolytes and such. So proximal collecting tubule, then it goes to the loop of Henle. Loop diuretics work here. Can you think of a loop diuretic? Real common one is Lasix, also known as furosemide. And then the distal collecting tubule is here, and this is where the thiazide diuretics will be working, and some of the osmotic and potassium sparing diuretics will work here, and then the collecting tubules, and then it goes and you'll go into the bladder of the kidneys, and then it will be collected. So that just gives you a good overview. I will play the video at the end, and the gentleman does a fabulous job, and you can see things flowing through, which I think gives a bunch of clarity as well. There we go. And with this particular diagram also, you'll see numbers in blue, and this is a percentage of that particular substance that is reabsorbed. So if it's red like this, reabsorption in red, 67 to 40%, I guess, is reabsorbed here. HCO3 is bicarb, 85% is reabsorbed. Some more sodium chloride is reabsorbed down in the loop of Henle. All right, it's fabulous. I mean, it's just amazing, the intricacy of what goes on in our bodies. So important to know where the diuretics affect the renal tubules and which part of the system it actually affects, so that you can understand a lot better. And of course, the potassium sparing diuretics do not cause the potassium to be lowered as a result. So spironolactone is one of the potassium sparing diuretics, so you would not need to supplement potassium for those patients. So all right, so we did touch upon some renal lab information earlier. and most importantly, creatinine, BUN, and urinalysis, those are like the first places to start. Creatinine normal level is 0.6 to 1.2 milligrams per deciliter, and that is typically in the male. Women are a little bit lower, like 0.5 to like 1.1 or 1.0. This is the end product of protein and muscle metabolism. As you see here, kidney disease is the only pathological condition that increases serum creatinine. So if you saw creatinine elevated in one patient and BUN elevated in another patient, which of those two patients would you think had the more severe renal problem? If you thought the person with the elevated creatinine, you would be correct. The BUN can be elevated for a lot of other different reasons, does not necessarily mean that there's been damage to the kidney. So as I mentioned, the creatinine rises when 50% of the kidney or renal function has been lost. And I gave my page reference, and that's 819 in the green NCLEX book. I would also suggest that you start doing that as well. If you're answering questions, give yourself, write down the page numbers and the reference. Even if it's just green NCLEX, you don't have to go through the whole bibliography kind of thing, but that way you can go back and look to recall where you found it. BUN, you'll see that particular number, 8 to 21. Sometimes you'll see a nice round number, 10 to 20. Both acceptable depending on what your lab in your hospital uses, but you'll find that each location is going to be slightly different. So know your normal lab values are always printed on your sheets as well, your lab reports. So this measures the nitrogenous waste in the urine, in the blood. Sorry about that. Earth to me. And elevation does not always mean that renal disease is present. So what else could cause that? Commonly, it's dehydration or a high protein diet. High protein diet / protein supplements. If you're doing an anabolic buildup and you're taking liquid supplements high in protein, got to watch out for that. Would not be unusual to have a high BUN in that case. Poor renal perfusion can also cause it, but it's usually a temporary kind of thing. Steroid use. So for the bodybuilders who are doing high protein, not drinking a lot of water, and using steroids, they can have significantly increased BUN, and over time that can also cause the creatinine to go up. So you have to watch out for that. And then BUN, or the GI bleeding, will elevate your BUN also because blood is a protein. The hemoglobin has protein in it, and so if you've got GI bleeding in your system, then as that waste is being broken down, you'll have the bigger protein molecules that will get into the bloodstream, reabsorbed, and that can cause the BUN to be elevated. Urinalysis, as we mentioned either in this lecture or I think it was this one, or medical terminology, specific gravity is compared to basically water. So 1.000 would be water. So 1.005 to 1.030 is the specific gravity of urine. So what is urine made of? 90 to 95% of it's water, and the other 5 to 10% is urea and uric acid, and toxic wastes, and just organic chemicals and such. Should be negative for other components. You really should not have red blood cells or white blood cells or any of that kind of stuff, bilirubin or any of that in your urinalysis. But in the RN Flip book, the RN Notes book, you can find on 195, the creatinine level is there. BUN, both of those have an NCLEX diagram next to it. I would encourage you to start learning the ones especially that have NCLEX alongside of them, and learn those first. And if you have time, you can fill in the others, but definitely learn the ones that have the NCLEX sign along them, because they're giving you a hint. Work smarter, not harder, right? Start with those and then expand from there. And in a urinalysis, you'll also have the color, which is typically yellow. pH of the urinalysis, there's a wide range from 5 to 9. So remembering that 7.0 is neutral. It can be a few points below, so slightly acidic to slightly alkaline, and that's considered fairly normal. Should not have any protein there, glucose, ketones, hemoglobin, bilirubin, urobilinogen, nitrite, leukestrase. If your leukocyte estrase is positive, typically means that on that dip you've got a urinary tract infection. We talked about the specific gravity. Some of the dipsticks will have osmolality, and that's a strange range there, 250 to 900. I've not ever paid attention. That must be a really sophisticated urinalysis. You also should have less than 5 RBCs and WBCs. Sometimes you'll get a contaminated specimen. If someone's menstruating, they may have some red blood cells if they didn't do a good wipe. You can also have some skin cells. And if there's a lot of skin cells, you know they didn't do a good prep for a clean catch. And also casts are just breakdown of the lining of the urinary system of the kidney itself, so you don't want to see casts. That would be unusual. It might be okay to see rare, what's called a hyaline cast. That is considered essentially okay, but otherwise none should be seen. So that gives you a little bit of an overview, and the urinalysis starts on page 202 in the RN flip chart. So acute kidney injury is when it's unable to work or excrete properly. As a result, there's an excess fluid volume that builds up because the kidneys are not able to filter properly, so they cannot create enough urine. So that fluid volume backs up, and you start getting the puffiness, fluid volume excess, and as a result, oftentimes need a diuretic to help get some of that going out of your system, because of the fact that if you have too much fluid, it can back up into your lungs and you can start hearing crackles and such in the lungs. So to help with that and to sort of goose the kidneys a little bit, sometimes they'll give you a little bit of a diuretic, like a loop diuretic furosemide. In addition, we have to watch with our acute kidney injury, electrolyte imbalances can occur quite easily. One of the big ones that we worry about is potassium. If it's too low, less than 3, we need to give either potassium by mouth or IV. Never give it IV as a bolus, and it's always properly diluted and at a very specific rate. I'm not going to go into that right now. It's not something that you're going to be doing. Just know that you're never going to draw up potassium and push it as a bolus. It's always going to be diluted in a larger volume, given over a larger period of time, and always have my patients on cardiac monitors because it can cause cardiac arrhythmias and such if it's going too fast, or you just want to make sure that you don't have any dysrhythmias. If the potassium level is very high, and it's going to be high in acute kidney injury because you're not filtering properly, and all of that potassium is staying in your body. If that happens and it's more than 6.0, you actually may need dialysis. And if you don't need dialysis and you have time and you want to try some other medication, the meds that you could use are K-oxalate, and that's sodium polystyrene sulfonate. It's a fancy name for it. And basically that is given and you poop it out. It pulls the it pulls the potassium and gets it out of your bloodstream, and then goes ahead and you excrete it as with stool. I'm going to give you this other slide, which I thought was really super helpful. No, you don't need to know all this right now, but my point is that you need to always be thinking about what is going on with your patient and how much time do you have. What is the hyperkalemia? They have renal failure. They were supposed to be dialyzed last week. They didn't get dialyzed. And what do we do to help them if our dialysis machine is not working? So if you have a longer period of time, like 2 or 3 hours, you can give them the K-oxalate. And you can give it rectally or you can give it orally, and it usually takes a couple hours. However, if the patient is unstable or it is critically high, and by critically high, I think we were talking about the article that I pulled this from, that potassium was greater than 6.5. And the answer, and we've seen this on a couple NCLEX or HESI exams, is to give 10 mLs of calcium chloride or calcium gluconate. That's given IV, and it works immediately within 1 to 3 minutes. This is good to remember. I have always thought, I've never given calcium, even as in the ER. I've given insulin followed by dextrose. The insulin drives the potassium back into the cells, but that still takes a few minutes to work. 10 units of insulin IV usually takes about 20 minutes. You always want to have, give them dextrose because that will also lower their glucose levels. So depending on how much time you have and how critically unstable the patient is, you can see how the different medications will work somewhat differently. And even albuterol, never have used that either, but 10 to 20 milligrams inhalation, so breathing treatment of albuterol, can help to lower potassium levels. Fabulous. So my point here is that you must always be thinking and reassessing. If you have a longer period of time, more than 2-3 hours, your patient's stable, you can always go with the K-Exolate. But if the patient is having dysrhythmias and is unstable, then most likely the doc will go with the calcium chloride or calcium gluconate so that we can get that potassium level down in a really short period of time, a couple minutes. There you go. So I hope you found that helpful. Let's see. And this other last med should not be used as an emergency treatment for life-threatening because it takes 7 hours. I've not even heard of it before. Patiromer. If you're really curious, you can go ahead and look it up. I'd love to hear more about it. And then the other thing that our kidneys do, which are fabulous, we talked a little bit about acid-base imbalance and acid-base ABGs, arterial blood gases, in the respiratory section. The kidneys are that third line of defense against pH changes in the bloodstream. So you've got the buffer system, then you've got the respiratory system, and now you've got the kidneys. They're stronger for regulating acid-base balance, but it does take longer than the buffer, the chemical buffers, and the respiratory system. Respiratory system works quickly because you can increase or decrease your respirations really quickly, and the body does it spontaneously and can change things readily. Kidneys take a little bit longer to have significant outcome. The kidney movement, the kidneys are effective to help balance blood gas imbalances by the movement of bicarb. So it's either going to be increasing the retention of bicarb or getting rid of it. Also, there's formation of acids and ammonium, and that kidneys can correct and compensate for pH changes when the respiratory system is overwhelmed or unhealthy. Because the trick to all of this with blood gases is the body system that's broken cannot be the body system that fixes the problem. So if your lungs are messed up, the kidneys have to compensate to fix it. If the kidneys are messed up, then the kidneys are messed up, then the lungs have to do the work. So the first line of defense is to keep the pH in homeostasis are, like I mentioned, the buffers. They're critical in maintaining normal body fluid pH. They sort of act as like hydrogen ion sponges. They soak up hydrogen ions when there's too many present, or they squeeze out hydrogen when too few are present. So when you hear that there's too many hydrogen ions present, that means that the patient is acidotic. If they don't have enough hydrogen ions, they're alkalotic. And then, of course, the lungs, they will hypoventilate. They'll slow down their respiratory rate and depth to retain CO2, or will hyperventilate to blow off CO2. So as I mentioned, body's always working together. Well, on a good day, right? And so here is a chart that I created or built off of a couple different YouTube videos that I'd listened to that I thought were helpful. So I would highly recommend that you start learning your normal values for your electrolytes as soon as possible, and in whatever fashion you would like to do it. There's a Picmonics link here. It's 39 minutes long. So when you have time, you can go back and look at that if you would like. In addition, there's a shorter one that I can send you. It's a 14-minute that talks about these particular values. And I like this range because they are sort of rounded numbers. So 1.5 to 2.5, magnesium. 2.5 to 4.5, a normal phosphorus. 3.5 to 5. So you see how it goes 1.5, 2.5, 3.5, magnesium, phosphorus, potassium. Okay, and then there's a little bit of a jump, and then it's 8.5 to 10.5. That's calcium. Then you've got your sodium and chloride. So as you can tell here, you can look and see, if you're drawing blood, you can tell that the sodium and chloride are the major extracellular ions, right? Those are, especially the sodium. And the reason you would know that is because of the fact that they're very high numbers. You're drawing blood, the blood that you're looking at, the plasma, holds this extracellular fluid, which has the sodium. The major intracellular excitation, the major intracellular ion is potassium. All right, so again, each of these things I've said what it does, what happens, some, just one or two symptoms if they're low, and a symptom if it's high. So let's just start. I'll read through this just because for the auditory learners, it may be helpful. So start with magnesium. The magnesium is the smallest of these values. 1.5 to 2.5 is the normal lab range. It's important for muscle relaxation. What happens if it's too low? You get muscle irritability. And if it's too high, you get decreased reflexes. Okay, phosphorus 2.5 to 4.5, responsible for muscle contraction. It's involved with that. It is reciprocal, meaning opposite of the effects of calcium. So if the calcium level is high, phosphorus levels are low. Okay, reciprocal means opposite of. So it's reciprocal in either being low or high with whatever's going on with calcium. So if the calcium goes up, phosphorus goes down. If the phosphorus goes up, calcium goes down. And so you can pretty much look at the symptoms that you'll have will be sort of opposite of what you'll find with calcium. So for example, if you have a low calcium and you've got a positive Trousseau sign and Schaafstek sign, which we'll not get into all that right now, but basically they're quick signs that you can do that don't require anything excessive. But with a low calcium level, both of these will be positive. Okay, and so with that low calcium, you'll get these symptoms. So what would happen? What would be the numerical value of the phosphorus in that patient? You're right, it would be opposite. So the symptoms for that patient would be hyperphosphorus, and you would get the same symptoms that you would get with hypocalcemia. Start learning slowly, 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 and building, okay? It takes time. It doesn't happen overnight. I want you to be exposed to this from the beginning and not wait until term 5 or 6, okay? We touch upon them frequently earlier on, but we need to start really building a good foundation to start with. Potassium is one that we always stay focused on, 3.5 to 5.0. It's important for cardiac and nerve function. It is the major intracellular electrolyte and is all involved with intracellular excitation. If it's low, the patient will have some pins and needles, like a numbness kind of sensation, tingling. The T wave on the EKG is flattened, and you may also see U waves on the EKG, which follow after the T wave, okay? It's like PQRST and then a little bloop at the end. If it's super high, you'll get paralysis. So you'll just like become flaccid. Tall peaked T waves on the EKG and bradycardia. Think of years ago, I don't even know if they're using now, if they're still doing it, but years ago, I'm told they used to use potassium IV bolus to kill patients. And think of what would happen. To kill a patient, does their heart rate go up or go down? It goes down to the point bradycardic and stops. It paralyzes them, and they get extremely bradycardic, and then they stop having cardiac function if it's too high. So that's a good way, I think, of remembering whether the heart is speeding up or slowing down if you have excessive potassium. Calcium is really important for neuron excitation and for bone development. If you have a low calcium, you may have a prolonged QT interval and hypotension, and then like I said, a positive Trousseau and Schrove-Steck sign, and we'll go into that definitely in term 7 if we don't do it sooner. With hypercalcium, decreased bowel sounds, hypertension, and profound muscle weakness. Okay. Chloride has to do with fluid balance, 95 to 105. Symptomatology, there's not a lot to say about that. If you can find some other things, typically sodium and chloride are hand in hand, and you'll get similar results or similar symptomatology with of the chloride in similar in location to the sodium. So obviously fluid balance is critical with the sodium, central nervous system, transmission, muscles, and it's the major extracellular ion. If it is too low, not have enough urine, not have enough sodium in your bloodstream, then you're going to have, if there's not a lot of sodium in your bloodstream, then there's not enough to hold the fluid into your bloodstream, so you'll have an increased urine output. If you are hyper sodium, hypernatremic, you'll have a decreased urine output and extreme thirst. But just think of what that's like if you get really super dehydrated. Okay, hope you found that helpful. Again, we encourage you to start your collection of medications now. Focus on your drug classes. The diuretics, you could start with the loop diuretics. And if you have a different medication card or format that you like, please feel free to use it. There's 1,000,001 different ways of doing it, but I want you to have a system that you're comfortable with and that you will continue to build through your nursing education. And as I promised, there is a summary of the 4 major classes of diuretics. And on here, I don't see the osmotic diuretics, but they were listed previously as well. So the major ones, the major classes for the proximal convoluted tube, that has to do with the carbonic anhydrase inhibitors. If you've already taken pharmacology, you may remember that for glaucoma under the name of acetazolamide, also known as Diamox, and also used for treatment and prevention of high altitude sickness. Loop diuretics are, their mechanism of action is in the loop of Henle. The thiazide diuretics, an example there is the hydrochlorothiazide, acts at the distal convoluted tubule, and then the potassium-sparing diuretics act in the collecting duct, and one of those is spironolactone. So I hope you find this useful as well. Feel free to print them, obviously, and let's see, we could print them and expand upon them and list the different medication examples on there as well. So as a final summary, I would encourage you to review the HESI hints that I pulled out here, and these are found in the red HESI book, which is the thinner red one. The 5th edition is where the reference numbers, the pages are located. So normally the kidneys excrete approximately 1 ml of urine per kilogram of body weight per hour. That's in a normal person, okay? 1 ml per kilogram per hour. If you weigh 100 kilograms, 100 mLs per hour usually. All right, for adults, the total daily urine output ranges between 1,500 mLs and 2 liters, depending on the amount and type of fluid intake, amount of perspiration, environmental temperatures, presence of vomiting, and diarrhea. That's found on page 91. Electrolytes are profoundly affected by kidney problems. There must be a balance between extracellular, outside the cell, and intracellular fluid to maintain homeostasis. A change in the number of ions or the amount of fluid will cause a shift in one direction or another. Major extracellular ions, as I mentioned, are sodium and chloride. The major intracellular ions are potassium and phosphate. So sodium and chloride, think of salt. Extracellular. Intracellular, think of the two that start with the P, potassium and phosphate. Okay? And body weight is a good indicator of fluid retention and renal status. Accurate weights are important. Be sure that the patient is weighed at the same time and on the same scale daily. As a point of reference, 1 liter of fluid weighs 1 kilogram. So if your patient gains 1 kilogram overnight, they have retained 1 liter of fluids. All right. If you have pounds, right? That would be 2.2 pounds. And so a pound is about a half a liter estimated, like 2 cups. All right, so I hope you found that helpful. Oops, and before I'll exit this, and then I will do my best to play this video at the end. But thank you so much for our time together, for listening to my presentation on the PowerPoint, and I will pull this up and see if I can do it from another location here, so that it will work and we can see it. I'm hoping, fingers are crossed, something's happening. Hooray. And so once this gets started, I'm not sure that you can see this still, but what I'll do is I'll verify after this ad starts. I'm sure that there's a really cool, smooth way of doing this. I have yet to discover it, so I really appreciate your patience. All right. Okay. I'm gonna have to stop. All right. Oops. Okay, so hopefully that last part was added as well. It has been a full evening. It is now the end of our hour together. Do you have any questions? Okay, if not, we will conclude, and if you need anything further, you can reach me by email, levers@concord.edu. Thank you so much, and I hope you have an excellent evening and that you do well retaining the information and building upon what you've already learned and continue to be successful in nursing school. Excellent. Thank you so much, and have a great evening.